and basically how this concept that we're going to talk about related to substance use disorders. This is the did you complete your pre-test? I hope you all did. And these are the learning objectives. So we want to be able to talk about what an ACE is and what the study is, and how these adverse childhood experiences actually were found to affect substance use. And again, it seems like just how does this relate as primary care providers in addressing opiate use disorder? So I'm going rogue here a little bit, and I added 3 slides. So just thumbs down if you don't like them, but this is one of them. So the reason I put this in was that initially, so a group of us, when we were deciding to do these presentations, my supervisor suggested I do this one. And initially when I saw it, I was like, ACE study, come on, because initially it's really tempting to think of this as being a one-slide presentation where you say, yeah, people who experience abuse, neglect, and severe family challenges are more likely to use drugs. And it's one of those things that you think, well, shouldn't that be intuitive? But then further thinking, and this is kind of where I check myself, and I want to kind of frame the conversation so it goes there. Many times things in medicine, although seem intuitive, turn out not to be, especially in behavioral health. Schizophrenia caused by high expressed emotion, and even more worse, you know, the idea within the last 100 years, lobotomy seemed kind of like a good idea. So it is incredibly important that, especially within behavioral health, we point to any evidence-based information. You know, it's an interesting thing. So if you guys are primarily coming from family medicine and the primary care field, it's an interesting thing. Once you step into addiction, it's stepping into kind of a behavioral health realm. And there's some criticism because we don't really have as many lab tests or other features that maybe other branches of medicine do. So anytime we have something that is linked to evidence, I think it's really important that we know it and we point to it. And then also how we apply this into clinical practice, I think, is important. So what is the ACE study? The initial impetus of it came from a Kaiser Permanente Department of Preventative Medicine. So around the 1980s, they were doing a preventative health program where they were trying to follow people in a weight reduction program. What they found was, in the midst of doing this study, was that and looking at their dropout rate, that there was a number of people that dropped out that, however, were actually successful. It was enough where the people decided, you know, let's look at these people, let's get some hypotheses, you know, why are they not engaging and why are some of them successful not engaging? So what did the study examine? So the key of the study was nowadays, like you'll actually find structured interviews that go through dozens and dozens of ACEs, or these adverse childhood events. This one specifically looked at 10 and how these 10 ACEs affected or were associated with physical or mental health statuses. So they experienced them in childhood, but how does it affect them as an adult? And then the overview is basically they found a direct and dose dependent, I mean, we think of doses in terms of medicine, but the more ACEs, there was this direct correlation with the amount of negative physical and mental health outcomes. So this is one slide that's meant to express that. Now, I reviewed myself and familiarized myself with the study. It would have been really interesting to see, you know, given this many ACEs, what was the actual prevalence. But in general, as you can see, the increased number of ACEs, the higher risk of negative outcomes. Now, I believe they were looking at something like 20 or 40 different outcomes. So when you look for a lot, you tend to always find something in research, but specifically, higher ACEs were found to be associated with health issues that included obesity, diabetes, depression, problematic behaviors like smoking, drug use, which later on we'll talk more about, and maybe more importantly, I don't know if more importantly, but in terms of quality of life, academic achievement, issues with work, graduation rates. Oops. Sorry, I have sausage thumbs and it went too far. Okay, so what is the ACE study? What did it look at? So this is one thing that I think is highlighted throughout. So there were 10 ACEs. 5 revolved more around abuse and neglect. So the 3 forms of abuse were sexual abuse, emotional abuse, and physical abuse. The 2 forms of neglect that they looked at was emotional and physical. And the 5 other categories used to be called forms of family dysfunction. They have renamed that as family challenges. So it includes, I have this separated a little bit differently in my head. So we have the 5 forms of abuse, and then we have a household history of substance abuse, mental illness, or incarceration, parental separation, and battered mother or domestic violence. This slide too really wanted to highlight that anytime that we, start naming things, it's helpful, but even look at something like mental illness in a household. That can mean so much and have we're limiting it to one event, but the actual effects and that it could have are just widespread. What does that mean? So a lot of times, even if we identify one ACE, it's usually signifying that there are clusters of them. And oftentimes the narrative of these families and these communities is one where there's multiple ACEs, but there's history of trauma, poverty. So it's an important thing to address. So there were 2 ways of the study, and they gave the timeframes there. And it was a survey of over 18,000 people, so that's a good number. But it was really the second wave that focused more on the linkage between ACEs and addiction. So this was a slide meant to show the prevalence. So when they looked at it, what were the prevalences of how many people indicated these ACEs? And just in general, looking at it, it's interesting to kind of think about what you would have thought would have been up there, but highest up there were substance abuse in terms of prevalence, physical abuse, and as we go to the next slide, so kind of key findings. So 2/3 of the 18,000 people had at least one ACE, and that's a very large amount of people, especially when we later see that even one ACE can dramatically at least increase the risk of certain health outcomes. But even more interesting, 1 in 8 had 4 or more ACEs, which you can imagine would just be a really difficult narrative in a situation that would require a lot of resiliency in that person to successfully navigate through. This was the interest in doing this study. So the thought is that going from bottom to top, adverse childhood experiences. And this is one where I kind of added some slides because, we talk about, the effects of trauma, and sometimes it's too vague and mystical. I think anyone would kind of nod their head to say, well, trauma affects neurodevelopment, which can affect cognitive impairment, which causes problem behaviors. That kind of sounds right and it makes sense, but I wanted to put some additional, an additional slide in there to kind of talk about maybe how that applies and then what we would as practitioners do to help address that. But again, so the adverse experiences lead to cognitive neurodevelopmental issues. You start to adopt or get these high associations with high health risk behaviors. You become unhealthy, and then you die early. This is a very depressing slide. So I want to go to, so this is the one I added, and it's super busy, but I'm actually very bad at putting PowerPoints together, but I think it'll be interesting. So I remember in residency, there was a book that they had us read called Perspectives of Psychiatry. And it was basically a way of looking at any mental illness through different lenses to help somebody kind of meet and come through recovery. What does that mean? So oftentimes, somebody comes in, you're depressed, here's some medicine, good luck with that. So what's the bigger look at it? So the 4 perspectives to look at any disease state or a problem somebody presents with are a problem caused by biology, disease. So like an actual biologic depression in a psychiatric sense. Dimensions of personality. So sometimes people, again, if we're using the kind of case scenario of depression, dimensions of personality, sometimes people may not have a biologic depression, but personality characteristics are chronically leading to conflict. So that's another example of where we would go and maybe address with interventions. Might not be a personality issue, it might not be a biologic issue, but it might just be kind of a learned behavior. It might be a simple learned behavior or a pattern of behavior, and that kind of starts to sound like personality. But, and most importantly, and we'll talk about this in a little bit, is life story. Sometimes people present with depression, and it's not that they maybe have a biologic depression, they may have the most wonderful personality, no problem behaviors, but their life is just a huge narrative to them of being a victim, of being beaten down. So all four of these different perspectives can come together and form aspects of depression. So how does that fit into this? So ACEs, how, looking at these four dimensions, how would they cause problems? Well, first of all, let's look at this over here. This is a picture of a brain. It's very lumpy. So inside, you have the limbic system. So this is the very emotional, base desire, reward-driven area. And then up here, you have your frontal cortex, which is basically all the things we as humans supposedly evolved to become more human and social. And this is also why, like I don't know, Marvel villains, like the ones that have the super huge brains, so it's usually their frontal lobe that's ginormous. So fun fact. Anyway, so as we look through this bottom piece here, the limbic system, it's meant to highlight and express our survival mechanisms, our drives, and it's very powerful. This frontal piece takes a long time or longer time to develop, and even well into your 20s, there's developmental changes where, I mean, this is the part where you have, again, down here, executive function, volitional regulation. Like, I want to punch the guy, but that's a bad idea because I want to keep my job. Some of this is very specific, but basically it is part of healthy and normal development to actually create connections between these two areas where, although this is the place where we think of like, this is where I have to really stop and think not to do that bad thing, there does start to be kind of some more automatic regulation of these very emotional areas. So this is where the disruptions of ACEs is one example of how they could impact. So, you know, it's simple to think of things as like, hey, these people had trauma in their lives, so this acting out as a learned behavior. Again, that could be true. They could learn bad behaviors, but I think it's important to maybe have more of a theory of the biology behind it. So as these synapses, connections, functioning pathways are developing and now developing badly, well, this frontal regulation is not going to work as well. Also, we know that people that experience these early ACEs also have higher issues of depression, anxiety. Similarly, let's look at the second dimension. Sorry, this is taking longer. I hope it's helpful, but we'll kind of go through these. But the dimensions of personality. So it is a personality characteristics, your basic ability to tolerate distress. And that distress tolerance comes from relationships between this emotional area and this frontal area. So again, ACEs affecting that development. Individuals that experience this are going to have a harder time having these kind of static personality traits potentially. This is one that's particularly important, and this maybe kind of verges away from the brain a little bit. How do ACEs affect things like goal-directed behavior? The example that I wanted to do is if you can imagine these individuals who have experienced huge amount of ACEs, they grow up with a very specific life situation that is very different than someone who has not experienced that. And what do I mean by that? Sometimes within medicine, and I think maybe in family practice, we see illness. We often take for granted very simple interpersonal interactions. So somebody coming in saying they have chest pain or issues with diabetes, you address the problem, you talk, and that's it. Sorry, that was way too simplified, but I'm trying to get a point and stay in the 20-minute time frame. But oftentimes, especially these individuals with addiction, it is different, meaning that, so as an example, I have never given a presentation to somebody over video media. It's very fun, by the way. But I have experiences giving presentations in other senses. So I'm able to take that experience of, I know how this works if there's actually people here, so I'm going to use those skills to use here. Well, the thing we have to understand is that these individuals that have multiple ACEs, they lack many of those very important experiences that they'll use to have their context. Many of them may have never successfully engaged with a primary health provider before, and they lack the skills. So it is it's something just to keep in mind, especially when we deal with these individuals with difficult disease states. And then finally, it's important that separate from biology, separate from these patterns of behaviors, oftentimes when we engage with these individuals, you know, there's this theory of therapy called narrative therapy, and it's actually really cool. But it's the concept is that basically we are a collection of stories. The most important stories that we bring to mind most often is it really kind of shapes how we see ourselves and how we move forward. So if the narrative that you constantly bring up is one of I'm a victim, I'm impoverished, I'm a drug user, you can start to see how these ACEs would actually affect somebody. So we'll have a little bit more clinical application in a second. So this was a slide meant to show when they did this study, who did they look at? And primarily the biggest thing to take from this is that most people, I mean, almost all of them had, I think, their high school education. There was a fair amount of college graduates, so well-educated Caucasian individuals. So in the second wave, they then went a little bit deeper, and then they wanted to show some of the questions that they asked. Basically, have you ever used street drugs? Yes or no? Have you ever considered yourself an addict or addicted to street drugs? Have you ever injected street drugs? And what did they, and they also looked at it at different time periods. So not only like, hey, because of ACEs, did you use drugs? How early did you start using? Early adolescence was considered 14. And you can see the other two by looking at the slide, but so they had early adolescence, mid-adolescence, and adulthood. This is what they found. Okay, so if exposed to just one ACE, you had a significant increase to an exposure to a second ACE. So again, these ACEs start to pile up. And I'm sorry, the video is kind of getting in the way of the slide. There we go. So again, median probability of exposure to two ACEs was almost 70%. And then this is again so when they did this second wave, it again highlighted the fact that ACEs tend to occur in clusters. So it's important to keep in mind. Each of the 10 ACEs increased by 2 to 4 times the likelihood of early drug initiation. So not just drug use at any time, but that really vulnerable 14 years. And so in addiction medicine, drug use before 14 is kind of that like, so if somebody says they've used drugs before age 14, that's like that marker for like, hey, there's a higher chance that this is going to be a lot more difficult to treat. And you can imagine why. They've been using drugs since they were like in middle school. So let's see, so ACEs also increased over everybody the likelihood of lifetime use, which is important to think about. So higher ACE score reflects especially early onset, and that was the strongest correlation. And again, and then especially for scores of ACE scores of 2 or higher. Let's see. Sorry. Okay. And this again is meant to show the increase for every increase in the number of ACEs. Again, if we imagine that they come in clusters, with each one there is an increasing risk. And again, I'm so sorry. I feel like I'm saying the same thing over and over again, but I'll say it in a British accent. No, I'm just joking. So again, the ACE score tend to increase the likelihood, again, and this is important, dose response. It's interesting, like these studies can be super helpful. And I think one thing that this study would call us to do is, as opposed to just taking a history, especially with these individuals that struggle with addiction, is to almost take more of a life story and a life narrative. Again, higher risk of drug use. Let me go to the next one. Oh my gosh. So in terms of, this is actually different. All right. So what proportion of the population exposed to one ACE will develop any of the following problems? So again, even just somebody with one ACE, we're not talking about people with chronic complicated life histories, but you have a significant increase in just individuals that have just one adverse childhood experience or event. So what do we do about that? So we talked about ACEs. ACEs are basically a form of trauma. We talked actually a couple different ways that trauma, either through biology or behavior, personality, or life story, would affect an individual. So what do we do? Again, like the big thing that we oftentimes, and it's kind of crazy if you think about it, within addiction medicine is kind of like the science behind it. If you look at most books, is like it hits the reward pathway. This is reward-seeking behavior. It's the high, it's the thrill of drug use. And the moment you start to work with this population, you're like, they don't look like they're having fun by the time they're coming to treatment. So there's got to be other things involved. And this is one. So the question, are individuals seeking to unconsciously relieve and treat their history of trauma? And again, always remembering that ACEs traveling in clusters represents a bigger issue, not one of reward seeking, but that, I mean, if you have family and community systems with high amounts of ACEs, you have family and community environments that have different thresholds for what type of behaviors are okay. So for an example, for early, I'm trying to remember what the study was, this is a separate one, but basically, one of the biggest factors that determined if a preteen or teen was going to use drugs was their parents and communities' thoughts about drugs. Like if it was okay to smoke pot, the chances of them smoking pot, especially if they did it in a household, was much higher. So what do we do, and what is trauma-informed treatment? So trauma-informed treatment, first of all, is just basically an understanding of what ACEs are and how they can affect individuals. So this is talking about motivational interviewing. I know this is a talk that I think that's going to happen in February. One thing, and this kind of goes back to what I was saying before, expressing empathy, which doesn't always mean like you have to believe everything somebody says, or just not use any kind of common sense in terms of making sure that a patient abides by boundaries, because sometimes that can be issues, but just to listen, to express empathy, and then again making it individualized, and listening to that story. Oh, do we have somebody jumping in? Sorry, I'm hearing things. Trauma-informed treatment. So there are a number of different forms of this, but what are, again, some tenets of trauma-informed treatment? First, it's realizing the widespread spread. Oh. It's realizing the widespread impact of trauma, recognizing the signs, and responding, actually using evidence-based policies and practices. With a highlight of attempting to not re-traumatize.
Whoever is not muted, please mute.
So again, one of the most important things to use from this, if we're going to take any kind of clinical application from it, is we have the information. It's important that when we do our histories or we're working with our patient, we identify it. So we need to collect the information, make sure that although these individuals may be difficult, that we connect with them, respect them. We teach them about the interrelationship between trauma and their symptoms, and work together with them and their families to help address these issues and these risk factors. One example of this is something called Seeking Safety, and this is actually a registered evidence-based practice, and it has been adopted and successfully in many different areas, treatment centers, areas that support individuals, severe mental illness, homeless shelters, domestic violence support groups, with again those same tenets. It's not like it is not like some therapies, and it's not some bag of tricks, but it's supposed to be this is our philosophy engaging with people. It's first of all making sure that we take a trauma history or a screen to see if individuals have experienced these ACEs, these events, and again teaching them about what that may mean. If they're having symptoms related to that, try and link them, and making sure that case management and wraparound services is something important that we do. And these were tenets of Seeking Safety. So making sure that relationships are safe, integrated treatment. If you just focus on substance abuse and don't identify trauma, there's always going to be a disconnect, and vice versa. So in this kind of the focusing on ideals, so there's actually so DBT and ACT are two other forms of therapy that basically try and teach you that, listen, your pattern of behavior has taught you that when life sucks, you use drugs. Well, we're going to replace that, okay? We're going to give you an ideal and you're going to practice it, but we're going to make a volitional choice that this is going to be the new you. So let's focus on where you want to be in the ideals versus basically saying, stop using drugs. And it goes through, again, kind of an integrated area, cognitive, behavioral, interpersonal. And it's very, again, important on respecting. You are allowed to set limits, but in how you actually respond. And this has been a really actually successful model. Okay, I'm so sorry, and we're almost ending. You guys have done great. So what's another application of this? So again, when these ACEs occur, and this is, when these ACEs occur, we talked about how they could affect biology or disease, either by messing up the connections, the development, or, you know, adding issues like depression or anxiety. So the risk of this being that individuals start to look like complex, difficult patients. So we need to have integrated teams. Again, you need to look at both the trauma effect as well as the effect of substance abuse on individuals' lives. Dimensions of personality, again, whether it's PTSD symptoms or, you know, this personality characteristics that come from poor neural development, individuals can be detached, they can be volatile, they can be difficult. So this trauma-informed approach is one way of like teaching staff how, this is how you like not take things personal, but still deliver important information to patients. You know, again, these individuals have lived different lives than many of us have, and oftentimes their ways may seem manipulative and inconsistent. And if we use those words, that's really going to be a giant axe to treatment. So it's important to have clear and facilitated expectations in addressing this. And again, you know, if somebody asks, well, why do I need medicines and therapy to go through recovery? Well, we need to build on your narrative as an individual in recovery. And medicine alone isn't going to do that. That's going to help out a lot. But again, here's a look at how ACEs may affect and why it's important to use this information clinically. And you guys have done it. A pluses. Good job. We talked about what the ACE study is. How it relates to substance use. Again, even a single one, more than 50% raises the chance or likelihood. And again, it's important. And it doesn't mean that like just if you are a lone family doc practicing in the middle of nowhere, you know, you don't need to have some huge team necessarily to make a difference. It's just being mindful of these things and knowing that there's actually a good deal that you can do, even if you're working by yourself. But when do I need to refer out? Or when is, you know, or this clientele is just driving me nuts. What is this? It's trauma, and it's the effect that it's having on the provider relationship. So references. I didn't put this together, but somebody did a really good job putting those up. Complete your post-test. Be good people. Make sure you, how do you sign in? Anyway, and then submit cases. That's it.
Thank you, Dr. Carpenter. And I really think the message of narrative to recovery is one that we all can aspire to. And I think we'll hear from our communities, again, our distributed experts across from nowhere to somewhere and everywhere in between, rural and urban areas as well. So I really appreciate your slides. I know that my understanding is we'll be able to share those slides, those updated slide sets with those of you who are participating in ECHO today. And so Kylie will facilitate distributing that because there's a lot of powerful information there. One thing I will just ask now, if there are clarifying questions or questions on the material of the didactic session we just had, please either unmute and then let us know what that is, or use the chat. I'll take a pause for a moment. All right, and maybe we'll use some of this information even during our case today. Excuse me, at this point, I just have two reminders. One is the sign-in is at your sites. We're all participating, so that's the answer to that question. please do keep your microphone on mute if you're not interacting with us. But then we'll have a period for interaction here to be able to unmute, and we will want everyone to be able to feel free and actually encourage you all to participate. And also just to be able to go forward, I'm going to ask again for the community's help, that it's all of our responsibility to help us maintain confidentiality, in particular during this next discussion, which will be our facilitated discussion of this educational case. I'm very excited about the discussion we'll have on today's case. And Dr. Arya, if you're available to just tell us, first, introduce yourself, and also, what are your goals for today's case? I think that's a really, even before we have you describe the case, why did you bring the case to us today? That'll be helpful for us to hear.
Well, this is Pat Evans. I'm going to introduce our distinguished lecturer here, Dr. Arya, in just a minute. We wanted to have some, we wanted to present a case that was very down to earth, something we don't seem to get very many perfect patients here. I think all of ours may have some of these pretty high ACE scores. We'll see. Dr. Arya is going to present a case, tell you about our lab results, and see what our experts here all think. Here you go, Dr. Arya. By the way, Dr. Arya just was accepted for a fellowship in medicine down in Alabama.
Arkansas.
Arkansas, sorry. There we go.
Yep.
Go ahead.
Okay, well, thanks, and thanks, Dr. Carpenter. That was a really good lecture, and I think there was a lot of principles in there that we could probably use in our own practices. So thanks for that, and maybe even in my case today. So what I'm going to present is a chronic pain patient, and I'll talk about the goals of presenting him today. He presents some of the treatment difficulties that we run into with a lot of our chronic pain patients. And sometimes the testing comes out inconsistent with what the patient is telling us, but we have a great relationship with the patient, and we kind of trust them intuitively or naively. And even if we don't trust them, we got to document things immaculately. So anyway, let me get to the patient. He's a 51-year-old male. He's got a history of chronic low back pain for many years. He does have past medical history of obesity, hypertension, obstructive sleep apnea, and he's nicotine dependent. He smokes about a pack a day. And then not really much else in his past medical history, and he's never had any surgeries. So when I inherited this patient, he was already on Percocet or oxycodone with acetaminophen, and he was taking 10 milligrams twice a day, although he had been tried on Norco in the past. An alternate or a previous prescriber had put him on the Percocet from the Norco, presumably because he wasn't getting the relief that he needed. And then also on reviewing his records, when I did get him, he had imaging for his back pain. In 2014, he had an X-ray that was positive for some levoscoliosis and then some degenerative changes of all the lumbar vertebra and some loss of height also. The radiologist was saying he probably had a fracture in the remote past. So that's the man's history. There's a couple of things that complicate his treatment. Number one, I think smoking interferes with the treatment of chronic pain. Number two, he has a job as a cashier, and he tends to do a lot of heavy lifting while twisting, and that really complicates his pain. These are two things that we discussed. He also has obstructive sleep apnea. He's been sent for a sleep study, but he said he can't afford the mask that he's been titrated for. In fact, he can barely afford our visits, and I think he's late. He's backed up on payments to us. So I think he's got a bit of psychological stress in his life too that probably doesn't help this treatment. So during the course of our time together, we did talk about lifestyle treatments in terms of changing his job, getting more physical activity, decreasing his abdominal obesity, quitting smoking and getting treatment for his obstructive sleep apnea, we were able to convert on a couple of those. I got him to quit smoking per him. What was the other one? We got a bit of a physical activity plan going. So those are two things, although he didn't really lose that much weight. So those are the two things that we were able to work on. But despite this, still having chronic pain, we tried tramadol also for breakthrough pain. It wasn't doing anything for him. And then he wasn't willing to have a discussion about high-dose NSAIDs because he said he tried them before. During our time together, he advocated strongly for TID dosing rather than BID, and I was initially very resistant to this. He managed to wear me down enough to where I said, we can try it for a month or two, but you got to lose some weight and you got to quit smoking. He was still smoking back then. So I caved and I gave him Percocet 10 milligrams 3 times a day. And I said, we'll see how you do. And if your pain doesn't improve, then we have to go into other things. I totally forgot about where he worked. And I went to that store once to shop for a party that I was going to have. And I saw him working there. And he was surprised to see me. And his face lit up. And he said, Dr. Arya, my pain is so much improved. TID dosing, I can work properly now, and I don't have to stress about increasing pain. And he was really, looked like a different person, kind of. He looked a lot better. So at that point, I kind of felt like I had done the right thing, and I still wanted to work on the lifestyle factors because in chronic pain, we like to go down on the dose, not up, and taper him down slowly. So he'd been getting TID dosing at that point. And then the first time that I tested him with Ameritox, the lab facility that we use for monitoring our chronic pain patients, he got some inconsistent lab results, and it really increased our kind of suspicion about this guy. So just briefly, he's taking oxycodone, and he tested negative for oxycodone. But then he tested positive for a couple of things that I'm not giving him. Now, they could be metabolites. There was hydromorphone, which is not a metabolite of oxycodone. And then there was oxymorphone, which could be a metabolite. But the important thing is there was no oxycodone. And we talked to the lab before confronting him, and they said, well, he must have not taken it for at least 2 to 3 days. So this is a guy who's in so much pain that he's advocating for TID dosing versus BID dosing. So the fact that he didn't take it for 2 or 3 days really increases the suspicion about the guy. So when we talked to him about this, he said, well, it's not really that unusual because on days off, I try not to take the medication. So when he's not working, he's not taking the medication. So, which kind of furthers the argument of why don't you change your job? You know, you should not be working in a job that makes the exact pain that you have worse. So anyway, at that point we had a discussion, and he became extremely defensive, and he said, I can't walk out of here without my prescription. Otherwise I can't work, and then I can't feed myself, or I can't pay my bills. So that's really the conundrum we have. Now, I think that I have a good relationship with him. I do trust the guy. And it could be that I'm naive, but I think that the guy really has a problem with pain. He may have a problem with opioid dependence. That's also a possibility. But I think the major problem here is his pain. And we probably didn't maximize on lifestyle factors like, I don't know, psychotherapy or heating pads or physical therapy and exercise program. I don't think we've maxed out those things. But in my opinion, I think he probably needs the opioid therapy for this time.
Well, thank you, Dr. Arya, and I think this will be rich for discussion around several aspects. I really appreciate you talking about the goals for the case, which quite frankly, as a primary care provider myself, as a family physician, probably seen similar scenarios countless times. And so we've got rich resources and also how would it apply to your environment. But what has been our experience in the similar predicament of trusting our patients, seeing that our patients have reasons for chronic pain, recognizing that it's difficult to sometimes tease out opioid use disorder, negotiating disparate laboratory testing, and even aside from that, the social economic status implications of needing the opioid to feed yourself through employment and increasing workability. Rich, for discussion, who would like to raise their hand or unmute to begin our discussion?
I would love to start, but if anybody wants to speak ahead.
You are our first volunteer. How can, please introduce yourself by name and let us know what you think of any of these issues.
So that is so first of all, I'm Jeremy Carpenter, and I'm the physician at Brightview in Ohio. And no, Dr. Arya, that is a great presentation. And there was a phrase in there, I wrote a bunch of it down, but you mentioned a phrase in there, you know, he finally wore me down. And I think that's absolutely appropriate. Like, these patients can do that. And it's an important line. It's a fine line from being kind of judgmental and dismissive, again, responding to that they're labile or they're manipulative, or just knowing like, hey, like this is potentially the effects of trauma, or they have lived a life that honestly that many of us can't understand. And, you know, honestly, I've come to understand too that a lot of times, especially when you have more difficult people, there are times when, and it's very difficult, the subjective of what they're saying is not matching up with certain objective principles, like you mentioned with the not as expected drug screen. So a couple of thoughts come to mind, but just one or two just to share. It's often something, again, when we have subjective problems, you know, ADHD comes to mind as well. Like, I mean, I don't even have an x-ray for that. Like, it's just like you fill out a screener and like basically anybody could endorse the symptoms. So what do you do with that? So, and I think I've tried to develop a way of engaging where I don't drive myself nuts, because you can't be a detective on everything, but you also don't want to be taken advantage of. So my approach would be this, you know, you pick what you think for the general population is a reasonable amount in terms of number, dosage, and that becomes a boundary for you. And I'm not saying what it should be, but let's just say that it was the 10 milligrams twice a day of the Percocet or oxycodone product. That boundary is actually okay to cross, and you may cross it just because of what they're saying, or even how much you like or believe somebody. But it's important to just to kind of have that in mind. Otherwise, because if we don't have boundaries and if we don't have limits, then we have people on all sorts of different things, and it's like, well, I was kind of doing this for this patient, but I'm doing this for that patient, and that's super hard to keep track of. So again, you keep an amount in mind, and it's okay to go beyond that. And then this is the second part. You maintain this posture of, and this is how I'm able to at least sleep at night. So you believe, and you move forward with this. You know, he's a patient, he's coming to you, he's seeking treatment. And that's the truth to keep focusing on. He's coming because of that. Now, separately, there's these exceptions that are happening. Like, and you can even say that, like, you know, I know that treating the pain is very important to you, and, you know, you are here, you're present. That said, there is this other thing over here, like, it's not in you all the time. So honestly, it's like putting two things on the table, and then you make a plan of what you want to do with it. And there's no right or wrong. You know, and once you've done enough of these, you kind of get some go-to things. You can say, you know what, I believe you have pain, and that's not the issue at all, but need to make sure that it's being taken as prescribed, so we'll go back down to twice a day. Another example would be if, like, it's in his, and then also, you know, people will say, like, with the other metabolite, I'm so sorry, the hydromorphone, people will be like, I have no idea how that got in me. And you don't need to get to the point where you get everybody to admit how exactly it got in there. You could even just say, you know what, I believe you. It sounds like you, like, honestly have no idea how that got in you. But here's the thing. You are in an environment where somehow that substance is getting into you. And that's a risk we have to manage. I'm not saying that you did it intentionally. I'm going to choose to believe you, but we need to come up with something to help manage that. And it might be as simple as, if it happens again, we're going to have to stop, because if somehow this is actually getting into you, it could have a reaction with the other medication. So then you bring them in for pill counts, you monitor them with drug screens, but you keep with that posture of like, I'm going to believe you, and I'm going to believe you're a patient here that primarily wants help. But we still have to balance these other things. So I'm going to kind of be quiet now and see if that made sense, or what you guys thought about that.
This is Lisa Faust. I was thinking, Dr. Carpenter, when you were talking, there's a little bit about this that reminds me of when you're raising children and they lie to you.
Yes.
If you keep pursuing them, sometimes you just teach them to be better liars.
Mhm.
And sometimes you have to simply allow people to save face and work
Mhm.
around it. So I think that one of the facts here is that there is not a plausible reason for hydromorphone to be in this patient's system based on what's being prescribed to him. And so obviously something else is going on here, but you don't have to rub his nose in it. And I think that's the point that you're making, Dr. Carpenter. I do have a couple questions. I wonder if, I have three actually, if I can have three. Do you have some kind of standard or random drug testing protocol that you use? Because you obviously started to test. My second question is, did you or had you thought about checking the PDMP, the prescription drug monitoring site? And third, I wonder if we have anyone in the audience who would be able, for anybody who's confused, to talk any about the drug metabolites and what you saw here, or how you would make sense of this, because I know that's often very confusing for people. I think I see Amy Weirmeyer raising her hand. So maybe we should ask Amy to weigh in on the metabolism question, and then maybe our presenter could talk a little bit more about the other questions.
Yeah, I was jotting down lots of notes about the metabolites and everything. I was so glad to hear you say that you talked to the Ameritox, the manufacturer of I don't know if that's the manufacturer or the agency that does the testing, but I think that's a really important piece, because I think it's very easy to misinterpret the results of a urine drug screen, not knowing if they're screening for, let's say, morphine, and what will cross-react with their assay materials and what will actually be identified. Are we actually identifying morphine? Are we identifying morphine metabolites, which would include hydromorphone? Did you, when you talked with them, did you get a quantitative result, or was this a present or not present result in the urine drug screen?
The facility that we work with gives us both. So if there's a qualitative positive, it'll give us a number, like a result from the assay quantitative.
Okay. I was wondering about that, because even hydromorphone, there can be things that cause false positives, one of them being dextromethorphan, an over-the-counter cough suppressant, which in and of itself, of course, has abusive properties, but could be a perfectly reasonable explanation for why the hydromorphone appeared if the person was taking over-the-counter cough syrup. So I like to try to see if there could be other explanations, and maybe you do that with the patient and maybe you don't. Maybe that's something that happens in your office. But I use an article on urine drug screen false positives that was published in Mayo Clinic Proceedings in 2017 that I'd be happy to share with the whole group if that's something you think would be useful. And the metabolite part, you're exactly correct that the oxymorphone, is a metabolite of oxycodone, and hydromorphone is not. And so the oxycodone would be would be a totally expected metabolite to show up in the urine drug screen. The reason, or one of the reasons I would think that oxycodone wouldn't show up, or something that could increase your confidence in the fact that he was still taking it, but oxycodone not showing up, is his metabolizer status. If he is a relatively rapid metabolizer, then he may go through oxycodone fairly quickly, metabolize it to oxymorphone, and not have oxycodone show up on his urine drug screen result at all. So those are the things that I was thinking of when you were talking.
Well, this is Dr. Schmitz as your facilitator. I think that's very helpful, and I'm really glad of all the interaction. It avoids me telling my country doctor stories, so I'll save those for later if we run out of it. But let's go back to Dr. Faust's questions around. I really think it is important to talk about how often are we using the PMP. There are often other confounders that result in some of the discrepancies around some of the testing. So any thoughts with regard to any of that, Dr. Aryan?
Well, I have a pretty broad panel of chronic pain patients. This one is pretty representative of, he's a good prototype. I check the PDMP every time I prescribe, just to make sure that they don't have any aberrant practices, make sure they haven't gone to the ER to get something, and if they did, then to make sure that they told me about it, because that would represent a transgression of our chronic pain program here at CFM. So yeah, I check it every single time. So it's usually monthly visits. They can't get more than a month's supply. I check the PDMP at every visit. And then there's a couple of other things that I do on a routine basis. I like to get a PH9, or at least ask them about their moods and screen for depression. I'll ask them about their sleep, and I'll ask them about their pain and what their goals are. So that's every visit with every patient.
This is Dr. McLean. I just had a question. You know, what Dr. Carpenter was saying, and I think alluding to, of you know, how can we join with the patient but not overprescribe? And I find myself in situations with benzodiazepines, a similar problem. So when the individual said, I don't use it every day, you know, for me, that would be an opportunity to say, oh, okay, how many days a week are you using it? And because I was curious, I assume he's filling a monthly script and using every pill, despite the fact that he's not taking it every day as prescribed. And so I was just wondering if you had a tactic as far as that goes.
Dr. Arya, do we have you there? Do you know if he was filling that prescription on time? And if he was being more clear about his dosing schedule?
Yeah, when I check the PDMP, he fills it on the day that I prescribe it, and we have a pharmacy on our premises, so he fills at our pharmacy. So on the way out, I assume that he just fills it, and then I thought he was taking it the way we talked about. Well, we didn't really talk about it that much actually, but now that we did the testing, it seems that he doesn't take it on his days off, which makes me wonder. I don't know what his work schedule is, but is he stockpiling some pills somewhere? Does he have a lot of days off? Those are issues that probably I should stay on top of, because then maybe he doesn't need, maybe by the end of the month he's got some pills left.
Yeah, and I think that was Dr. McLean's point, and I can say in my practice, I certainly had patients, my practice was a logging town, and so we had loggers with significant musculoskeletal injury who were working for a living as loggers. And I think that we did often find that patients might go from 90 pills every 30 days, or one other tendency is to maybe prescribe every 28 days, which results in a same day of the week dispensing schedule, so you avoid the weekend refill and some of those concerns. But if you do it every 28-day prescribing period, you can sometimes titrate those opioid, I call it the opioid burden. How do we get patients to a similar level of function or even improved level of function? And there are life function tests, I believe, scales that you can have patients rate with a reduced opioid burden, whether that's milligrams per tablet, whether that's morphine equivalents per type of opioid we're using, or whether it's a total number of pill count per 28 days that is lower than it used to be. And so, again, maybe the patient would utilize 70 pills every 28 days, or you can multiply, 3 times or 2 times the number of working days, and then as opposed to 90, for example.
Outstanding point.
Hey, this is Dr. Patel. I'm one of the docs over at Brightview. I just had a couple questions, and I'm sorry, I didn't get the full case summary, but a couple things that have been said is just clarifying that urine screen and urine toxicology confirmation are two totally different things. So we as within this group should be making sure that we're clarifying whether it is a screening test, which is only right up to 65% of the time, or confirmation screening or confirmation testing that is run either GCMS or LMS and get those results to us. And then in the cases of those patients that are filling their medication on supposedly a monthly basis, I have no problem asking them, how much are you really taking? To Dr. McLean's point, it's a matter of, if you're not using it that much, and we have a tendency, all of us have a tendency to put the medication in the pill bottle into the closet or into the drawer, so that way, in case we need it, and sometime in the future, we still have it. And these patients that are especially pain management patients or substance use disorder patients, we need to try to re-educate the patients that if you need another prescription, it's time to fill up another prescription. Those medications that you have left need to be dispensed of and disposed of appropriately. And I think that the more we continue to educate our patients, the better we'll be at reducing the number of active tablets that are out and about in the community.
I think that's really helpful information. Can you again clarify a little bit? You mentioned that there's the screen tests and the confirmatory tests. I think you used a bit of shorthand language around what the confirmatory tests, either the lab or the type of test. I wasn't sure what those initials stood for. Our other audience members may also benefit from just a little more detail on the nature of confirmatory tests and how those might be available even from a rural setting.
Yeah, so the liquid chromatography and gas chromatography that are run on a mass spec device. Ameritox, I'm fairly certain, has that information is probably being run on an analyzer somewhere. There is so much money in that. It's less now, but those companies are going to find a way to get those specimens turned out around for us fairly quickly. If you're getting a quantitative number, then they probably are running it on some kind of GC or LMS machine. Please do take care not to put too much emphasis on numbers that are going down. That doesn't necessarily mean that they're using less of the medication. There's a lot of factors that can go into that as far as how much they ate, what time do they take the medication, are they losing weight, is it a depot form, is it something that they are getting off the street that they don't really know what they're taking. So there's that combination of information as well.
Thank you, and I think that's very helpful. I will just want to also open it up to some more of our spoke sites now at this point about your experience, whether that's with screening testing, confirmatory testing, availability of that, and maybe also with regard to some of your protocols that you may be using either in your outpatient settings or other settings, even through your rural emergency department settings, with regard to appropriately managing patients presenting with a similar circumstance. So for example, I know that in our Minot residency program clinic, they are following a protocol. I can tell you in my rural town experience, when I had a patient who was, for example, positive on a screening test for marijuana, but he also lived 3 houses down from me, and was also, we did business together and saw each other in the grocery store. I really like that approach of saying, I laid it on both things on the table. I believe you have pain, and I believe you that these medicines are helping you. I also see that this is a screen that's positive for marijuana, and in that case, in that particular state, I explained to him that my ability to be his doctor and prescribe medicine for him was related to this discrepancy and situation that we needed to deal with together as a team. So I think there's been a lot that has come out here. I'd like to see if any of our other spoke sites have, again, without revealing confidentiality in your small towns, what are you experiencing? How are you dealing with some of these challenging scenarios? I found it challenging. I still do.
This is Bethany Peterson from the Fargo-Moorhead area. And there was a couple, some of the questions I had have already been answered or asked. But I just wanted to say, first of all, that I think the fact, the amount of time that you've spent with this patient is pretty impressive. And the stuff that you know about him already. You know about his job, you know about the difficulty with that he can't afford his mask for his sleep apnea, and that he can barely afford the appointments for you. I'm just wondering if does he have insurance? Is there any, sometimes there's for medication, there's support that they can get to help pay for their medication. Is there anything like that to help him? Does he need to get connected to insurance? And is there somebody in your clinic that can help him with that financial stuff? Because from what I hear too, and speaking of the ACEs study, there's a lot of psychosocial, we can't dismiss the psychosocial stuff that happens in these people's lives. And he may not be to a point where he can even process or think about moving to a different job, because it's one more thing to do. It's one more stressful thing. It's routine for him. It's safe for him. And even though we know it for him, it would be better to get a different job. He may not be at the point where he's ready for that. And that can be talked about, through motivational interviewing and maybe getting him to that point. But at this point, it doesn't sound like looking for another job is even in his capacity to think about. So just some of those psychosocial things, if there's an opportunity to address those, we know that can be really helpful. The other, and I was really, one of my questions was, are you using screening tools? So are you screening his mood? Are we screening for suicide? The other, the other thing too is like the opioid risk tool. So if we're questioning what risk is he at, even for a history of trauma, that could be potentially helpful too in having the conversation about and using that non-judgmental approach is, your screening tool tells me this. There is we just started using, not in my clinic, but in some other clinics, because of the ACEs study and because of what we know about it and the patients that present to a primary care clinic, we started implementing a screening tool for trauma, for PTSD that's designed for primary care. So that might be something too that would be really helpful, just to learn more about the patient.
Bethany?
Yeah.
Do you want to say any more about the opioid risk tool? I don't know if everyone is familiar with that or not.
Sure. The opioid risk tool is helpful because it incorporates some of that. So it doesn't tell us whether or not somebody is addicted or, if they're abusing their medication, but it gives us more of a sense of based off of what they're reporting, their mood, and it indicates on there if they've had a history of, I should pull it up. We have it built in our system. But if they have a history of trauma, it doesn't indicate necessarily what type of trauma. And then it tells you if they're at higher risk for potential abuse. So it's not going to tell you if they're abusing it. That's for us to kind of figure out and weed through, but it will give you more of a risk level, just kind of like a suicide screener, that it will tell you, are they at a higher risk of completing suicide right now based off of this? So it's similar to that.
So I think to frame our discussion then, what I'd like to do is several of you actually have volunteered to contribute resources that can be distributed. So please email those resources to us, email those to Kylie, and we can send those out to the group, including some of the screening tools that you all were mentioning. I think that's one of the values of Becco, is to be able to share tools and useful algorithms and resources to be able to distribute those to the group. Dr. Arya, if you don't mind answering one of these questions, I think it is true that there are many people that have socioeconomic needs that need to be met. I also am impressed with how well you know your patient, how small the town is, that you interacted with him out in the community, even though you're in a small city. And I guess I would ask, especially since I'm the faculty there in Minot for community medicine, are there community resources to help meet the socioeconomic needs of patients in Minot? Are there social worker referral systems? Is there public assistance or otherwise people who have economic stressors can't afford their care? Maybe they can't even afford the copay for the visit they're scheduled to have with you next time around. So how do you deal with that? And then after we put you on the spot, I might again ask if there's any rural communities that can comment if this case relates to them. So I'd like you all in rural, even more rural than Minot, to get ready for that. But Dr. Arya, how do you deal with the psychosocial stressors?
Yeah, so the psychosocial and in this case, economic stressors are probably contributing to this guy's overall care and probably not helping with his pain issue. Last time we spoke, or a couple of times ago, he said that he's getting caught up on his bills and he's planning to get the CPAP mask because he thinks it's going to help him. And I think his insurance covers some portion of his monthly gym membership, and he was able to join the YMCA. But yeah, I agree. This is probably a place where more can be done to find out what can be done to alleviate some of his medical bills or insurance bills. To be honest, I haven't done anything myself, and he hasn't really reached out to me. But that would probably be a good place to see if we can maximize his care.
Well, excellent. So let me generalize and ask one of our rural communities to tell me what you've done in a scenario that I've been in many times, which is we literally have had patients who show up after the clinic closes. Let's say the clinic closes at 5. We would often have patients show up at 6 o'clock to the attached emergency department at our critical access hospital rural health clinic because they didn't have to pay a copay. They had the inability to pay the copay, excuse me, to come see me in the clinic at 4:50. But they would see me as the ER doctor on call at 6 o'clock for the exact same problem. And then, of course, we tell them, well, follow up with your regular doctor. Oh, that's me. In the clinic, which was literally down the hall from the ER. So who's had this experience, and any advice for those of us who have patients with both economic stressors and a need for treatment, in particular here around chronic pain and opioid use? At least tell me you can relate to the issue.
Here at Williston, yes, we can relate to the issue. We do not have outpatient social work. We have social work for inpatients. There may be a social worker at the community mental health clinic, which we have intermittent communication with. It's not the world's best communication style, but getting somebody in there, it can take several weeks. There is a private counseling clinic, which I am not fully aware of all of their resources, but again, it costs money to go to that private counseling clinic. That's not frequently covered by insurance. Again, we end up being the court of last resort most of the time.
So at least, thank you, Dr. Small. At least we can commiserate around that. Does anyone else have any suggestions with regard to seeking community resources in some of these vulnerable patient populations? I think, again, we talked about this on one of the past Project ECHO conferences, saying are providers, in fact, to a certain extent, afraid of asking a question because the answer is yes. If we find that patients have a history of these ACE factors and have a lot of mental health needs, is one of the things obstructing treatment the fact that we're going to just recognize we're in a boat where patients it's going to be very difficult for us to coordinate resources toward the patient because the patient's contribution, economic or not, is lacking. Advice for us, can other people console us around these predicaments sometimes primary care finds themselves in?
This is Bethany again. It was really interesting when I first started in the primary care clinic, and I'm in Fargo, and I started in Fargo, now I'm in Moorhead, but when I first started there, it was very eye-opening and very, actually quite surprising to me that when someone would come to me with someone with a substance use, or even the patient would literally come in and say, I need help. I want to go to treatment. So they were ready. I mean, it's not even that we needed to convince them, and they said, well, I don't know what to tell you because we don't have any treatment centers here. And I was like, oh my gosh, I just came from one. I worked at one for 7 years. So it was really surprising to me that even in a town of Fargo who has multiple, the providers just didn't know the resources. So something that I created was just a resource list of this is the option, these are the options, these are the insurances they take, these ones you can go to if you don't have insurance. But it was amazing to me how little was known, even in our large town. And so, yeah, in rural communities, sometimes they're not even there. And so it's hard to know the resources. But here, even we have the resources potentially, not always, but we have the resources and they still don't know about it. And so I don't know if we did the same thing for like counseling, because we oftentimes can't get our own people into our own Sanford Health Counseling because they're full. So we created a list of psychiatry options, chemical dependency options, therapy options, methadone clinic, like, the resources, and we're able to provide that to the providers and the nurses. And it literally is it's a time-consuming task, but I don't know, and maybe a nurse could be tasked to that in your clinics. So we have health coaches and nurses, and they're very good about digging that out and handing it out. And but having like a list or even just having an option that someone in your clinic could create instead of just having to recall it from.
I think that's a great idea. And in fact, in our rural community, which was the third poorest county in the state, we did create lists of resources, including subspecialty resources. We were referring to Spokane or Coeur d'Alene, for example, where I was practicing in a very rural area. The other thing, too, I think, is that there may be an opportunity to mobilize and activate your community around this, or even our state around meeting some of these needs. For example, in my county, we actually started a volunteer community clinic. Now, in that case, we were most often perhaps treating malignant hypertension for $5 a month with a generic blood pressure medicine. But in that community, we actually were able to create a new resource because of the fact that we needed it. And so we also had subspecialists who frankly volunteered one appointment a month to see patients who were coming through this volunteer community clinic, which operated on a sliding scale depending on ability to pay from $1 to $10. I'm just giving you an example. Maybe there are people even on this call who could volunteer some resources, or there are people within your community who are willing to work together to account what resources are available to patients and how you can begin to meet some of those needs. Short of that, I like the idea of setting boundaries. Do we sometimes as clinicians need to set boundaries of what our expectations are to be able to partner with our patients in meeting their health needs, and realizing that if we're doing no harm, we may also be doing some good, and also helping them to avoid other maladies within the healthcare system they may otherwise face. I do believe that, Dr. Arya, your continuity of care and your ability to care for this patient and knowing your patient and their circumstances has really come through this case. We've got about a couple of minutes for some more points, and then I'm going to wrap up with the last of the housekeeping.
Dr. Schmitz, this is Lisa Faust. I just wanted to tag on to what you just said and what Bethany said, because I think there is, so as I'm thinking about this case in particular and reflecting on the population who present, and the challenges that primary care faces with how to get assistance and how to refer patients. There are certainly patients who need referral to substance use disorder treatment or psychiatric treatment, but sort of speaking to the didactic presentation today about ACEs and people's psychosocial status, sometimes what people need is simply social services, and they may need public health or just social services. So this case, for example, I think he's a long way from the doctor being able to say, I think you might have a substance use disorder problem. I think you should go here. That's not going to happen. And I think what the physician has done here is to seek understanding and to begin to engage the patient. And I think Bethany was speaking to a lot of the psychosocial variables in poverty that he struggles with. And so sometimes it's not actually mental health that people need to be connected to. It may be other social services. And that's the kind of thing where you also could develop a list like Bethany is talking about if you don't have social work in-house. But I think we want to be careful that we don't ask our primary care providers to leap off into feeling like they have to refer all these patients to mental health or substance use disorder treatment. Sometimes you just want to look for what other community resources are there for social supports to navigate things.
This is Dr. McLean, and I would echo that. The other thing I would mention is all of us have clinical associations that we belong to, or at least could. And I think that the power of utilizing those to lobby for resources, I think, can be very powerful. I think certainly the legislature would look back to us and say, well, are you doing everything you can? But when we answered, yes, within our clinics or whatever, we've looked at these resources, we've made efficiencies, but it often does come down to there are more things that need to be provided that we just don't have any ability to do, to provide. And then en masse, I think that we can use political willpower to effect change.
So Dr. Arya, I'd like to return to you to see if we've at least begun to address in your young career some of the questions that I think will continue to come up and some of the goals for presenting the case today. Any comments you have, Dr. Arya? Or Dr. Evans, if you're there as well. All right, and with that, I'm going to just see, are there any other questions or last comments? Oh, go ahead. Okay, I'm going to ask if there's any last questions or comments regarding the case or regarding today's didactic. Hearing none, I just want to remind everyone to complete the post-test and evaluation. Don't forget to sign your rosters for the coordinator to be able to send in. Those of you who offered resources, please contact, again, Kylie. I think you already are. I see she's sharing her email, so we can, again, coordinate those resources coming out to you. I hope that you've enjoyed today. I think it was very successful. I really appreciate the distributed expertise, and I look forward to even more participation from our spoke sites in the future. And our next Education Echo Clinic will be in about exactly 2 weeks.
Yes, Valentine's Day, February 14th.
All right, we're going to put our heart into it there. Thank you, everyone. We're actually going to conclude just about 3 minutes early. Thanks so much to our speakers. Thank you to Dr. Arya and Dr. Carpenter. Thanks so much.